on patients at risk. South Carolina legislators are considering bills that would expand scope of practice for nurse practitioners and physician assistants. Concerned for patient safety, the South Carolina Medical Association is fighting to block these dangerous bills. Today, we're joined by Holly Pisarik, Senior Vice President of Advocacy and Policy Counsel for the SCMA, and SCMA President Dr. Mayes DeBose.
Mayes DeBose, a family medicine and geriatric medicine physician at a town called Sumter here in South Carolina. Proud to have been independent from day one. Thankful to my father, who was also an independent physician. It was more common in his day, but he at least gave me the courage and the vision to see that it could be done, which when 20 years ago I was coming out of fellowship, that was a rarity and becoming more rare. Proud member of the SCMA, happy to be in some leadership roles through that. Blessed by my time getting to know just huge heavy hitters like Holly. It's just been really gratifying to me to be able to work closely with them and to see how they do what they do.
My name is Holly Pisarik. I'm the Senior Vice President of Advocacy and Policy Counsel for the South Carolina Medical Association. I've been with the association for almost 5 years now. I am a healthcare attorney by trade and have worked in various aspects of healthcare law. Since I've been practicing, I've worked for a large law firm representing hospitals. I have been a part of a governor's cabinet as a cabinet director of the licensing agency of physicians and other healthcare professionals. I've been a governor's chief legal counsel and obviously most recently here with the association, and happy to work with physicians like Dr. DeBose who are committed to access to care and quality care for their patients here in South Carolina.
Well, thank you to you both. And it's been my privilege to be involved just a little bit there in South Carolina. And I have just been so incredibly impressed with the work that the SCMA has been doing and the work that you're doing personally. So let's launch into what's happening right now on the ground in South Carolina. Let's set the stage for our listeners and walk them through some of the main scope of practice bills that are on the table in South Carolina right now.
South Carolina has 2-year legislative sessions, so we are right in the middle of a break between the first year and the second year of the legislative session. But last legislative session, there were several bills that were introduced that didn't pass, but will still be alive going into January into this session. So there's 2 Senate bills in particular that are troublesome for physicians in South Carolina from a patient safety perspective. Senate Bill 44 would allow physician assistants to practice without any physician supervision. Currently, under South Carolina law, they're required to have a supervising physician. This would allow them to practice under an attestation statement and no physician supervision after 2,000 hours postgraduate clinical hours. And if they wanted to switch between specialties, only 1,000 hours of the new specialty prior to independent practice for the new specialty. Their bill also references not only medical acts, but surgical acts in the bill. And they also already are asking for parity in pay in that bill. So that's Senate Bill 44. In Senate Bill 45 would allow nurse practitioners to have independent practice. Currently in South Carolina, they must collaborate with a physician. There are no mileage restrictions, so that physician doesn't have to be within a certain mileage radius. And physicians can supervise or collaborate with up to 6 NPs or PAs at any given time. That was a compromise that was reached back in 2018 and 2019. This bill would remove the collaboration requirement after 2,000 hours of postgraduate clinical hours. But with either the PA bill or the NP bill, like most states, nothing that says what must happen during those 2,000 hours. It's just an hourly requirement, and there are no quality measures, there are no process measures, there are no requirements about what that has to look like, or how in depth or how involved that has to be with the physician. So those are the 2 bills that are our primary focus. There's some other scope bills that are out there. There's a pharmacy bill that would allow pharmacists to diagnose, treat, and prescribe, essentially. And of course, all of these are under the guise of increasing access to rural health care in South Carolina, which we know that's not what these bills would do, but that seems to be the justification that's being put forward to support them.
Dr. DeBose, it sounds like they're playing a little fast and loose with the unsupervised practice of medicine, saying you can practice as an NP or a PA after just 2,000 hours of experience, and for PAs, switch specialties with 1,000 hours. Just remind our listeners what physicians need to do in order to practice unsupervised.
Well, my goodness. I used to not like to talk about this topic, but the more I've been involved with this type of advocacy, the more I've realized it needs to be said. Humility is not our friend, specifically on this front. So 4 years of undergrad and then passing the MCATs, 4 years of medical school, 2 years, which are heavy duty in classroom learning, 2 more years of rotations through all the various specialties. Then you go on and match into your residency, which could be anywhere from 3 to 6 years, depending on your specialty. And then sometimes the fellowship after that. Not all areas of medicine require it. Some it's pretty much mandatory. So, you could be hitting 24th grade or so very quickly by the time you get through all of that. But the number of hours that we're talking about in the current legislation gets eclipsed by just basic medical education. And I think people have always respected physicians. We have a little bit of an image problem right now, and I think we need to be careful with that. But um, I think I think most legislators know that physicians get a lot of training. I don't think they know how much training physicians routinely get, and we need to find good ways to respectfully, politely convey that message. And that's where Holly's skills have been so invaluable for us because she talks to these legislators every day. They're not bad people. They only know what they know, and we have to find ways to communicate with them and work with them and build relationships with them.
I think that's so well said. And of course, it's not just the number of hours that's so different, but also the quality, the standardization, the fact that not everybody that gets into medical school makes it all the way through or gets into residency. There's a lot more than just the sheer number of hours. But to your point, how do we effectively communicate that with legislators? Holly, you're talking with a lot of people on the ground. What are you hearing from them? What do they understand about the differences, or do they?
So I think Dr. DeBose is right. I think there's a general understanding that physicians go to school forever, and are very well trained, but don't understand that there are tests along the way that measure for competency. As you said, people wash out of residency, people wash out of medical school. It's not just you get in and you're going to become a doctor. There are measures along the way to make sure that you are safe to treat patients independently before you're ever turned loose to practice medicine. And so we have to drill down and turn it from just this general understanding that doctors are very well trained, very smart people to exactly what that means and exactly how regulated the ACGME accreditation for these schools, for these residency programs. It's meaningful. It's not just anybody, anywhere doing a residency. If you finish a residency, we can be guaranteed that there was standardization in your training program and that you are qualified to do what you are trained to do whenever you finish. And we have to draw the distinction between nurse practitioner education in particular and PA education in that those same quality standards don't exist along the way. The rigorous entrance requirements into the program don't exist for a number of the programs. The clinical hours are a lot more flexible. Nurse practitioners in particular, a lot of times are required to get their own clinical training hours. And if you talk to some of these physicians who serve as preceptors, there are not the same measures throughout that training that are guaranteeing the quality. And then at the end, there aren't tests. They do take a board certification exam, but it is characterized even on the website as an entrance exam. It is a baseline exam. It is not a rigorous exam for competency and quality. And so we really have to draw out those distinctions to show, and we have visuals that we use to just illustrate the stark difference in the two training, not just in hours, but also in competency and quality.
One of the things I've noticed that legislators will do is they'll give an example of an exceptionally well-trained and experienced NP or PA and say, why can't this person practice? They have all this experience. But what your point is, and I think it's the most important point, is that we have to gauge a profession by the minimum quality of the person that's being permitted to practice. So people will say, well, there are bad doctors and there are excellent PAs and NPs, and that It is relative, but what we do know is that there is a minimum standard, and that is what we have to look at, not the outliers that may be the best and the brightest of any given profession.
Right. What I like to say is we have to regulate to the least qualified individual that could do what you're allowing them to do under this bill. We can't pick and choose and have the ones that come testify who have been doing it 30 years, who are RNs 10 years before they ever went back. That is not the rule anymore. We have to regulate to the person who's going to go straight through from undergrad to nursing, never actually practicing as an RN, a 100% acceptance rate program, a 100% online program. And we're able to pick and choose their clinical training hours and then come out 2,000 hours with little supervision and then independent practice. That's the person that we have to be concerned about the most.
It's so fascinating because to think about switching specialties, I'm a family doctor. So if I said, I think I'd like to be a rheumatologist, I cannot go and shadow a rheumatologist for 1,000 hours and then call myself a rheumatologist. I would have to go back and do a complete residency. Now, maybe you could argue, could there be some kind of bridge or something like that? And, maybe. But the point being, doctors can't just flip into other specialties, right, Dr. DeBose?
No, I agree. And when we've had these discussions before, Holly and I had a breakfast with the senator, and he brought up something along those same lines. And my comment was, I can see your argument that maybe medicine has over-engineered our competency training. And I can see an argument there, but that's not even close to the other end of the spectrum that we're trying to make decisions about non-physician accreditation and training, autonomy and independent practice. Moving back off of some of their massive hours is a whole different argument. And that came up in the hearing several months ago that physicians understand why that level of training is required. And should you decide to become a rheumatologist, you may not want to go back and do residency, but you would see the value in it. You would not complain that you had to do it because you would see that you needed to do it. And I think that is a near unanimous feeling among physicians. And I think that's a nugget of something that kind of we need to find a way to message and let people know that the oversight is a big deal because this has come up a number of times that, nurse practitioners want independent practice, but they still want to be regulated by the Board of Nursing. Well, I mean, that's not good. That's not safe. The Board of Nursing was not built for that. Board of Medical Examiners is built for that. But that's been another sticking point with any kind of middle ground that we try to reach. So it's a tough problem. It really is.
It really is. And before we move on, I'll just highlight briefly a brand new study just released in the British Medical Journal, BMJ, that did a review of physician assistants, and they have said unequivocally in this article that there is not evidence to support unsupervised practice by PAs, that the only evidence out there is working with close physician supervision. They're calling for a return to that in the UK because they're seeing a lot of problems with expanding PA practice. And I'll just point out, PA studies, educational system is a lot more standardized and more lengthy, I would argue, than nurse practitioner training. So if this is the case for PAs, I expect we would see the same and even more so for NPs, that there is no evidence that they can safely and effectively practice without direct physician oversight. So let's move on to a couple of challenges that you have faced as a medical society, which is the role of other interested parties in the healthcare system. For example, we'll talk about the letter of support that Blue Cross Blue Shield of South Carolina sent in supporting expanded scope of practice. And also the FTC acting director sent a letter of support talking about market forces and allowing consumers to make choices. Talk a little bit about those entities and how that's affected this discussion.
We'll begin with the FTC. As an organization, several years ago, we supported the repeal of Certificate of Need in South Carolina. And we believe, just like Dr. DeBose said, he is an independent physician. We believe in competition in the market. We believe in allowing forces that allow independent physicians to compete with hospital systems and private equity groups. And so we are very much for, where it is safe, eliminating barriers to practice so that physicians can stay independent and compete. And so that has been, in some respects, turned against us, that we supported the repeal of certificate of need, but yet here we are on this side of the argument, and we are not supporting elimination of what they are characterizing as barriers to practice for nurse practitioners and PAs. We see it totally different. The certificate of need argument was repeal of government regulations that was just really controlling market forces, but didn't have a safety component. With the repeal of certificate of need, those entities still have to be licensed. There are still safety standards that they have to comply with in order to get licensed as a hospital or add hospital beds or become an ambulatory surgery center. Here, with nurse practitioners and PAs, there is a safety element involved that wasn't there with the certificate of need argument. And one of the things that the FTC relies on and the other proponents of this bill is, well, there's evidence that says it's safe. And as you said, Dr. Bernard, the evidence that they use to support that argument, and even the evidence that's relied upon by entities like the FTC and other think tanks, grossly misconstrues what those studies show. It shows in a very limited context, in very limited circumstances, with physician involvement. And so we don't think that it's apples to apples that the FTC said we should repeal certificate of need, and then we were on that side of the issue there. And so now the FTC is saying we should allow NPs and PAs to practice. They're overlooking a safety element that didn't exist with certificate of need. In terms of Blue Cross Blue Shield, they're supporting independent practice, relying, I'm sure, on some of the same safety data that the other entities rely on. And frankly, it's less expensive. They will reimburse at a lesser rate. And so I'm certain that would be advantageous for insurers to have more NPs and PAs practicing because they could reimburse at a lesser rate. But as I pointed out initially, S44 is already asking for parity in pay. And so it wouldn't be cheaper if that component of the bill passed. And we've seen it in other states where independent practice has been allowed. Initially, the justification is reduced healthcare cost, but then parity in pay comes along behind. So even if parity in pay isn't a part of the bills now, it will come. There is a formula for all of this across the country. And so there will be parity in pay as another wave of this. And it won't be, if that were to pass, you wouldn't have any cost savings associated with PA or NP independent practice. You would just have lesser trained individuals doing the same thing as physicians.
Anything you want to add on that, Dr. DeBose?
You make some enemies along the way, and you hope that personal relationships prevail. We're not always going to see eye to eye with different things like this. Insurance companies and hospitals have a wholly different reason for arguing for independent practice. The parity in pay is an interesting piece. I don't know if that'll make it through the legislation. That's more of Polly's area to read the tea leaves on that kind of stuff. But, it's hard. And hopefully we can avoid the devolving into the kind of left-right politics that we see all over the place today. Hopefully this can be a conversation. This can be a discussion. This can be reasonable and see what the outcome will be. But this is not the area the doctors are very good at. This is the area the doctors like to avoid. And we've done ourselves a disservice over the years by avoiding it because you have to be in the game. And if you don't want to personally do it, you need to support the people that are willing to do it.
Well, I definitely want to dig into that. But before I do, I just want to ask a question about the hospital systems. We know that most physicians are now employed. So glad that you're able to maintain your independence, Dr. DeBose, and I have as well. It makes it easier for us to speak out. I'm imagining, not sure where the hospitals stand on independent practice, and does that make it hard if they're in favor of expansion for physicians to speak out?
I think it does. We already see that, SCMA members that are in leadership roles, getting called into early morning meetings with hospital executives that they are technically employed by. And it makes it very difficult. And again, that's where I say that you have to hope that those personal relationships win out. I'm thankful to be independent so that I can do that without that fear of retribution or being blocked from advancing in my career. My career doesn't depend on hospital C-suite patting me on the back and giving me attaboys, but some doctors do. And not every specialty in medicine can be independent. There are plenty of specialties where you pretty much have to work with the hospital system. That's a reality, but But again, I think that goes back to that collective voice. We have to support the people that are willing and can speak on your behalf for those things.
I would echo what Dr. DeBose said earlier. We do not consider our hospital counterparts, our insurance counterparts as our enemy in any of these conversations. They are all necessary components, and we work with both of those entities on different initiatives. We just have policy differences, and we are going to vigorously fight for physicians and the patients that they represent without making it personal. Because again, all of those other components are very necessary, and we want to try to preserve those relationships where we can. But we're not going to back down from fighting for physicians and the patients that they treat.
I love that so much. And even though I know it's really hard for many doctors to speak out because of the issues that you correctly elucidated, Dr. DeBose, I think we need to remind ourselves and our colleagues that it is, of course, it's about us as physicians, it's about our profession, but above all, it's about our patients. And that's what we're fighting for. That's who we're fighting for. And we have an ethical obligation of beneficence and non-maleficence and to fight for justice and for patient autonomy, where patients actually have the ability to choose a physician, which in some cases, in some states, they're losing that ability because of these legislative efforts that have been intended to increase access. But what happens is, crazily, patients are losing access to physicians. But I think, to your point, if you can't speak out, support the people that can. And that's what SCMA is all about. That's what you're there for. And I just think you have done a tremendous, incredible job of advocating for your physicians and the patients that they serve. I want you to talk more about SCMA, what you've done, and explain to our listeners why it's so important to participate and support your medical associations.
Well, I'll tee up Polly on this one. We just had a hugely successful Physicians Day at State House, and I was happy and privileged to be part of it. But there was so much work behind the scenes, and Holly and Rochelle just did a tremendous job. But I'll let Holly talk about that.
Yeah. So, there are physicians who don't have the independence to speak for themselves because of their employment arrangement. There are physicians who are busy. They've got, busy lives. They're working a lot of hours. They've got families. They've got children. They've got lots of other obligations. And there are plenty of ways to get involved with the SCMA, even if those things apply to you. We are fighting. We are at the State House every single day that session is in. We are talking every day that we're there to legislators to advocate on behalf of physicians. We coordinate things like Physicians Day because myself and the other lobbyists that represent the South Carolina Medical Association can speak to legislators till we're blue in the face. But if you can get a physician there to talk to them, that is so much more impactful. So we provide opportunities. It can be intimidating to try to get to know senators and representatives if you don't know them, how to even get engaged in the process. It's a toxic process. Some people want nothing to do with it. But that's our job, is to facilitate those relationships, to make it easy. I've spent hours on the phone with physicians, preparing them for testimony, preparing them for conversations, writing talking points. And so it is my job to make it very easy for physicians to get engaged, to feel comfortable, but to have opportunities either in Columbia or back at home close to you, and fight for the issues that you all care about as physicians on behalf of your patients.
I really, really, really want our listeners, to understand how much work you have done on this issue. And I want to contrast it to some other states that I've watched over the years where these bills come up and it's like, oh, well, I guess that's it. Because they just say, well, there's no way we can block this. The politics are what they are. We don't have enough doctors, so let's just go to the table or let's just let them do what they want to do. And South Carolina and other states too, Texas has done this, and so there are other states like you, but you guys are really, to me, setting such a model of saying, well, we may not win this, but we are not going down without a fight. And that is so important because I think so many doctors, when I talk to them, it's like this sense of like, it's too late, the horse is out of the barn, and it's almost like this learned helplessness. And so when I see people like you guys fighting and saying, well, we're just gonna do what's right and we're gonna fight. It's so inspiring to me. And I hope it's gonna inspire other physicians to say it's not too late. We can still make a difference.
So, Dr. Bernard, to your point, it does feel sometimes like it is David versus Goliath. It is insurmountable. The political, winds are already blowing against you. But our physicians are not willing to just go home and have that attitude. And so I'm very thankful to be working with a group of physicians who have said, we could lose this, but we're going to fight for our patients on the way down. We had 2 Senate subcommittee hearings in the off session related to this, and we spent a lot of time trying to be very thoughtful about every component that we offered in testimony. And we put together over 3 hours worth of testimony that we offered. We made 4 points into that testimony, which is the safest, most cost-effective care is physician-led healthcare. And then we had physicians, Dr. Bernard, you were under that point testifying to that. Dr. Batson testified, the author of the Hattiesburg study. Our second point was physicians are the most highly qualified member of the healthcare team to lead because of the standardization, rigor, length of training, with all the things we talked about. And we had physicians who run residency programs, who precept NP. We had an NP come in and testify. We had a PA come in and testify. We had a medical student come and speak on behalf of medical students under that point. And then our third point is there is no such thing as no risk or low risk medicine, because there is this misperception that somehow primary care is not high risk medicine. We're just treating earaches and colds. And we talked a lot about how it is to make an undifferentiated diagnosis and how difficult that is. And that's one of the most difficult skills that you spend years learning that skill. And then finally, our fourth point was there are problems with access in rural South Carolina, and we don't want to ignore those. But eliminating physician-led healthcare is not the answer to that. The data in South Carolina shows that when we eliminated restrictions in 2018 and 2019. And then we offered other things that we thought would help because we didn't want to be deaf to the concerns that there are access issues. And then we had a physician on the front end offering kind of the opening statement and a physician on the back end offering the closing argument. And we treated it like a trial, really. And we're going to go in and we're going to present this evidence, and win or lose, we're going to have said everything and leave it all on the mat and really give the legislators the information they need to make an informed decision. And if they make the decision that independent practice is the thing for South Carolina, we offered everything from our perspective to help them make an educated decision on that.
Yeah, Holly had a great game plan for that day. And yeah, I was laughing. That was my first day that I really got a taste of the gamesmanship that happens in those committee hearings. So my opening statement got postponed until well after lunch, near the end of the day. And after lunch and all that, my mouth was so dry. I just, there was a little bit of home field advantage in doing all that. So, but Holly did have a great game plan. Back to your question about the SCMA and what we're doing. I've not always been an organized medicine mindset type of person. I was not that person in medical school. I did some leadership stuff, but I didn't do AMA. I just didn't feel like I was wired that way. But a older doctor in my area asked me to be in his spot for the board of trustees for the SCMA. And that was really my first introduction. And I just learned so quickly how invaluable it is. And it saved me from that learned helplessness that you referenced, Dr. Bernard. I know you have them. I have them. Doctors that say it's too late. We can't do any good. You can't move the needle. It happens. I do believe, with the SCMA, we have so many things we want to do better. There's so many things that we want to tackle and conquer and improve on. But the more that I've been involved with other state societies, I do believe you're right. I think we are one of those shining lights, and I think we can hopefully show other states that you can build this, that if you put the right people in place, the physician's passion is almost always there. You don't go through medical school and residency and fellowship because you don't care about your patients and the science behind it. I mean, we love what we do. We hate the system oftentimes, but if you're going to be that lemming running off a cliff with the rest of your fellow physicians and not trying to do something different, the system will get worse. I'm thankful to be part of a group that is passionate about it and has seen successes. In medicine, if physicians are not being heard by hospitals, by state organization, by legislators, by CMS, by insurance companies, or even their own colleagues, it's a very hopeless feeling. And so that's that idea of a collective voice that's really resonated with me. We need that across the country. We need that, and I'm thankful that SCMA is that. American culture is not really wired for membership in organizations nowadays. We're all very independent. We do our own thing, but I think the pendulum will swing back, and people will see that you need a group. You need a voice. So
We need a tribe. And I'm so grateful to that colleague of yours that asked you to sit in. I have a similar story to you. When I was in medical school, I was just trying not to fail. I was trying to get through gross anatomy. And then in my residency and internship, I was tired and exhausted. And like these young people that are already so involved, I'm just inspired and proud that they can do that. I wasn't there. And then I think I was a little naive. I started very, idealistic. I started my career, and it probably wasn't even until maybe my 40s that I was like, hey, wait a minute. This is not good. Maybe I should start figuring out how to get involved. And then I was lucky enough to also have people that reached down to me and said, here, why don't you sit at the table with us? So I love that you said that. And I would say to anyone listening to take this as a sign that you can also get involved, either through just joining or reaching out to somebody that is already in organized medicine in whatever capacity that is, and just starting by showing up. Because I'm sure, Maze, that person reached out to you because they knew you. And so you have to make connections. We have to make connections with each other, lift each other up, and work together. And so I think everybody should be, at a minimum, a member of your local medical society, certainly on your state level, because that's where a lot of these things are happening. And if you can do more, that's great too.
amen. That deserves an amen.
Is there anything that I missed that you wanted to talk about?
The only thing I would add, Dr. Bernard, is thank you to you, because you joined hands with us in fighting in South Carolina. And it's important for the South Carolina voice to be heard, but it's also very important for people who have seen what's going on around the country, and that voice to come speak to our legislators, and to someone like you who's actually dug in and read the footnotes in those studies and dug in to see what do these studies actually stand for. Your testimony was invaluable. And I think I would speak on behalf of Dr. DeBose and I both, I think, in saying we are happy to join hands with any other state that is in the same position that we are in, because if we succeed, and one of the things our legislators ask, probably like many other legislators, what are other states doing? We're happy to come in and fight with you, because we all are stronger together. And so I think not only join in South Carolina, but join hands across the country to make an impact on behalf of patients.
And I just give a lot of credit to the AMA Scope of Practice team, to Kim Horvath in particular, for making the connection with us. And she also is the person that got me connected with Texas. It is so helpful to have also that overlying organization that does work with each of the states individually, so that we can come together, because there's a lot of strength in numbers. Even though we all do things a little bit differently in our state and our community, ultimately, we're all bound together by the practice of medicine and the profession of being a physician. Thanks so much for listening. I hope you enjoyed this episode. If you'd like to learn more, I encourage you to get the books Patients at Risk and Imposter Doctors. They're available at Amazon and at barnesandnoble.com. If you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician-led care and truth and transparency among healthcare practitioners, then please join our group. It's called Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. If you'd like to appear on our podcast, you'd like to share your story or discuss a case or an article, please send me a message through the website patientsAtRisk.com. Thanks so much, and we'll see you on the next episode.